Hi, my name is Juliette. I am an advisor to Students for High Impact Charity and I work with Innovation for Poverty Action in Sierra Leone. I got involved with international development after studying political science at University of Sciences Po in Paris. And after 1 year of studying international development, I joined the behavioral lab in India associated with Abdulatif Jamil Poverty Action Lab. So you might have already heard of randomized trials, but in the medical field, when researchers want to test the effect of a new drug, they randomly assign half of the people in a group to take the drug and the other half to take a placebo, which is a fake pill. It looks like the pill, but it doesn't have any drug in it. By comparing these two groups, they can measure the effect of the drug. And the same method applies for measuring the impact of social programs. The main advantage of this method is that it allows us to control for external factors that might have had an effect on the results. And measuring social programs can help us overcome our misconceptions about what works to solve social issues, and it can also help government to find out which method is the most cost-effective to solve a social problem. So here in Sierra Leone, I work on randomized controlled trials that looks at how we can provide social incentives so that people are more likely to access healthcare.
So before I explain to you what these social incentives are, you might wonder why we would need incentives in the first place. In Sierra Leone, it is free for mothers to get all the necessary vaccines for their child under 5 years old, and since 2010 and the free maternal care initiatives, consult a nurse during their pregnancy.
Most children come for the first vaccine, but many don't come back for subsequent vaccines. And considering that full immunization can significantly reduce the chances of a child becoming sick or dying, it's very important to identify the causes of this high dropout and the most effective way to overcome them. Dropouts may be due to indirect costs related to immunization, such as transportation costs or income loss from taking a day off to go to the clinic. To overcome these costs, previous evaluations have tested the impact of food and financial incentives and have found positive results. For example, in India, they found that giving 1 kg of lentils at each immunization visit and a metal plate at the final visit increased the rate of full immunization by 18 to 39%. In Nigeria, they found that giving cash incentive to pregnant women increased the rate of tetanus shot by 20%. It might also be the case that women don't know about the benefits of immunization, or they are aware of it, but they don't value immunization as much as they should. And there is no evidence so far that social incentives might have an impact on people's belief and behaviors toward immunization. The social incentives implemented in this study are in the form of color bracelets. The main intervention is that when a child comes for the first vaccine, he receives a yellow bracelet. When he comes for the final vaccine, which means he completed the immunization schedule, he receives a green bracelet. The theory is that first, it will allow mothers to make it visible in the community that they went to the clinic, that they take care of their child by getting all the necessary vaccine. And secondly, the fact that some babies in the community are wearing the bracelet will show to other parents that people value immunization, changing their belief and behaviors and making it more likely for them to immunize their own children. So the trial I'm working on will test this theory. So how does this randomization work? Unlike in the medical field, where we usually look at health outcomes at the individual level, these randomized controlled trials look at behavioral change of the whole community. So the randomization here takes place at the clinic level. 120 clinics have been randomly selected in 4 districts of the country and randomly split in 4 different groups. Each of these clinics offer the same immunization series to children in their community. 30 clinics correspond to the pure control, which means in this clinic we collect the data on how many children came for each immunization, but we don't hand out any bracelets. 30 clinics belong to what we call the bracelet control group, which means children receive only 1 bracelet for the first visit, and the color of the bracelet doesn't change as they come back for subsequent visits. Now, the remaining 2 groups of clinics are called the treatment clinics. In 30 of them, children get a yellow bracelet for the first visit and a green bracelet at the fourth visit. And in the 30 other clinics, children receive also a yellow bracelet at the first visit, but the green bracelet is given out at the fifth, which is the final vaccine. The reason why we have two different treatment groups is to work out whether parents are completing the immunization series because of the bracelet and the message it delivers, or because of the importance of immunization itself. If they do it because of the bracelet and its signal, then since in the first treatment group, children receive the green bracelet at the fourth vaccine and not at the fifth vaccine, they have no incentive to come back for the final vaccination. So we would expect children in the second treatment group to be more likely to be fully immunized than the children in the first treatment group. But if they don't do it to signal, but because they have learned on the importance of immunization, then we would expect the difference between the two groups to be fairly small.
On our team here, we have around 12 surveyors. Their role is to monitor how well the program is being implemented in the clinics, which is very important because IPA works with government so that the clinic staff themselves hand out the bracelets. The surveyors also collect data on babies that come for immunization and conduct surveys on clinic staff, caregivers, and community members.
One of the goals of the caregiver survey is to identify the mechanism behind the behavioral change towards immunization. And to do that, we need to ask questions that are not always easy to ask, such as how many people in your community do you think went for immunization? That is the knowledge of people on other community members' immunization visits. We always have to make sure that these questions are asked in the most neutral way possible, but at the same time that the survey is probed enough for the person to fully understand the question. It's not always easy, but the quality of the data is very important. My job here is basically to analyze the data as it comes in, adjust the data collection tools to improve the quality of the information we are collecting in the field, and follow up on implementation problems that might occur in the clinics. I find this job very stimulating because the implementation context is challenging. Nurses in the clinic struggle to keep good record of their data, and we always have to find solutions to make sure that we are capturing all the immunization visits. So that's very interesting. And I also joined IPA and this study because I want my job to make a difference in people's lives. And I think that by working in this kind of research, I contribute to evidence that will influence policymakers and ultimately improve a lot of people's lives. So yeah, I find this very motivating.